It is 12:03, and we are here, Dr. Payne Show, ready to roll. Phone lines open, 416-870-6400, star 640 on cell. I think today we're going to talk about pain management, stuff that people suffer from all the time, fibromyalgia, all that stuff.
I think that's a good guess on the
Considering
Dr. Payne Show.
Yeah. Let's talk about pain on the Dr. Payne Show, as opposed to finance. Your mortgages. Let's go.
So, yeah.
How was the week?
Very good. Yours?
Good, man. Tell me some stories.
Yeah, well, instead of a clinical case, I thought we'd touch on some stuff this week regarding the chronic pain, fibromyalgia stuff, because a lot of people are experiencing this. A lot of people are being diagnosed with this. They don't really understand it, and we've kind of gone through this. So, let's start from the beginning. A person has pain, whatever, it could be in one area, it can be in multiple areas. You're never going to diagnose with somebody with fibromyalgia or chronic pain right off the bat. It's a diagnosis of exclusion is what we call it. And so what it essentially means is once you're able to determine that there's no other pathological cause for this person's pain, let's say a person has widespread pain throughout their body, there's a lot of things that could be very bad that could be causing that. And we've gone through this. Could be maybe something autoimmune attacking the joints, creating an issue, might be something neurodegenerative, could be a severe infection of some kind. There's so many different things that can cause widespread pain. And these things tend to have very good tests to rule them in, rule them out. Once you start getting to the point where this person who has widespread pain, there's no real diagnosis being given, so you can't determine it's something autoimmune, it's not something neurodegenerative, which is all good. You would want that, right? If you're experiencing widespread pain everywhere, you don't necessarily want there to be anything bad because it could potentially be very bad. And so oftentimes what ends up happening is once you get to the end of the line and you've seen all the different specialists and they're not really able to determine what's going on, usually a rheumatologist will say this is fibromyalgia, which is just really an overactive nervous system, a very sensitive nervous system that makes this particular person experience pain more easily maybe than someone who doesn't have this overactive nervous system. And so then the question becomes, what created this overactive nervous system? And it could be, that's a much harder question to answer in terms of me giving like a blanket statement and saying, here's what always causes fibromyalgia. It could be very, very dependent on the situation. Maybe it's somebody who's been experiencing some chronic pain. They're not really sure what it is. It goes on for a long period of time. They go through all the different testing. There's nothing there. And now there's that psychological component that tends to be present with the chronic pain. And that's really what fibromyalgia, chronic pain is when there's widespread pain throughout the body. It's often related with some type of depression, anxiety, and also related with some type of sleep disturbance. And so that's really chronic pain, fibromyalgia. Now, a lot of people don't want to accept that maybe they have fibromyalgia or that they have chronic pain and they think there's something to it. The reality is once you've had everything ruled out, sometimes you just do have chronic pain, fibromyalgia. And again, fibromyalgia is a term to kind of give us a term to explain these situations. How do you explain somebody who has widespread pain without any particular root cause?
It's a symptom, not a diagnosis, really, isn't it? It's not a disease. It's like saying I have a headache. It doesn't mean that's what, you know what I mean? You've said that before.
Yeah.
It's a sign, right?
It's different in the fact that there's no specific root cause to it, I guess.
Right.
But I mean, also having... The other option is if we didn't have that term, we would just be essentially saying to people, well, there's nothing wrong with you. And it's like, well, no, there is. I have pain. And so sometimes putting a term on something also helps, because also that term, when you just break it down, fibromyalgia just means pain of the fibers and the muscles, so of the soft tissue of the body. And fibromyalgia can be experienced in many different ways. For some people, it could be numbness and tingling. For some people, it's actual sharp, dull, achy pain throughout the body. Sometimes fibromyalgia happens after there's a severe injury of some type that gets dealt with, and then the person can develop that. So many things can lead to chronic pain, fibromyalgia presentations. Then the question becomes, how do you manage these people? Because that's what really everybody cares about, is, okay, now you've told me what's wrong. What do I do to potentially get better? Fibromyalgia, chronic pain, they're chronic for a reason. There's not going to be any magic pill, any magic cure. I actually had a call this week of someone who said they were listening to the show and they were hoping that I had, quote unquote, a magic cure for pain. And I quickly called that person and said, right off the bat, let me just dispel that belief. There's no magic cures for anything. What I'm here for is to really help manage things the right way and give you the best approach that will help you manage your case to the best as possible. But to have a magic pill or a magic cure that's just going to eliminate everything just doesn't
not realistic.
No, it's not realistic, and it doesn't exist. So with these people with chronic pain, fibromyalgia, it tends to be very multifactorial, where you got to work on the physical side. That meaning passive therapies, physio, chiro, massage, those types of things. The more active therapies on the physical side, so you making sure that person's doing their exercises, staying healthy, eating healthy. Then there might be assistive devices that are implemented. Maybe they need a knee brace. Maybe they need different types of supports for their feet that maybe help them a little bit.
Something in the home, possibly.
Yeah, something in the home, things to make things a little bit easier. That's kind of the assistive devices. Some medication is often part of that program, so they might need some type of medication to help manage their pain. Because there's such a psychological component around this type of presentation, a lot of the medications can also work on those areas. And then there's also the psychosocial interventions, the cognitive behavior therapies, and the different types of things that you can do from that end. So people with chronic pain, fibromyalgia, you have to deal with it not just from one angle, but from that whole spectrum of what could potentially help with pain. And that's really the best way to go about it because of how many things cause chronic pain, fibromyalgia. And again, this is something that it's a diagnosis of exclusion, and it's often not related to just a simple. You can't narrow down to just a simple structure in the body that, hey, here's what's wrong, and let's fix this one problem, and it's going to be gone. That just doesn't. That's not what fibromyalgia and what chronic pain is. And there's this. We talk about a lot. The stigma around mental health. There's a big stigma around this about fibromyalgia and chronic pain that people don't, when someone says I'm in chronic pain or I have fibromyalgia, their friends, their family, their loved ones will dismiss them like, oh, it's just in their head. It's just in their head. And they're not realizing that, no, this is actually something that they're experiencing and it's not fake. Yes, there is a psychological component that exacerbates their symptoms, but that doesn't mean it's fake. It's as real as it is.
We'll talk more about that angle of it as we seem to be doing each week because it becomes more of an issue with people. Your phone calls as well, 416-870-6400 star 640 on cell at 12:11 on your Saturday afternoon. Ready to take your phone calls. Dr. Payne Show, Talk Radio, AM 640. Info@paincarecanada.com. Info@paincarecanada.com to reach Dr. Lou anytime or 1-855-55 Lou DRLOU. That's outside of show hours. Hey, Ed. Good afternoon.
Good afternoon.
What's going on, pal?
Okay, I've been to so many doctors about this, and none of them can figure it out. My wife and I both suffer from this, so we thought it was environmental. We had the house checked out, everything. We both will get cramps in our muscles and Charlie horses. To the point where when you get that Charlie horse in the back of your calf and it balls up, goes to a big ball. Oh. Man, I get that so many times, and even on the top and side of my foot. Mm-hmm. If I'm laying in bed and I stretch my toes forward, boom, my toes, my feet, my calves will all cramp up on me.
Okay.
I take melatonin before bed. And I take, what's the other one? Help me sleep, and for muscles. Starts with an M. Melatonin and magnesium.
Malibu rum. Oh, okay.
Right?
Okay.
Maybe I should try that.
Yeah.
But I'm telling you, I've been to my family doctor, my pain doctor, my cardiologist. I've been to the special clinic down at St. Mike's. Mm. I was there for half a day. They ran more blood tests on me than I can count.
Right.
The only thing they found out wrong is I have carpal tunnel in both wrists.
Right.
Right. They ran electricity charges up and down each side of my body. Right? Nobody can figure out what's causing these. Like if my wife and I go out walking around in the mall or something that night, we're going to pay for it.
Okay. So I think, you've done the right thing because obviously if you had told me you had this and you got to start ruling out the more serious things. So you got to make sure this isn't a nerve issue. And so you had nerve conduction studies done.
Yep.
You got to make sure that there's not related to some type of deficiency in a mineral or a vitamin, which it sounds like you've had that looked at. Yeah. And then, the fact that you and your wife are both experiencing, I would agree with you that potentially it's environmental. Now, environmental doesn't just mean, the air in your house and those types of things. What's your guys' diet like? Are you guys smokers? Are you guys healthy? And those are the other environmental things that you should consider, because what's the typical diet for you and your wife in a day? What do you guys usually eat?
Yeah, it's just my wife and I. I drive a truck. And she's home she's not working. She hasn't for some time. But we eat fairly well. We eat a lot of vegetables in the morning. Like I leave for work at 12:30 in the morning.
Okay.
I grab a coffee on my way down, and for lunch I usually have toasted egg, bacon and egg sandwich, or a BLT on a bagel. That's like brunch.
Right.
And I don't eat a lot of junk food. I don't eat a lot of sweets. I'm not a big drinker. I don't drink during the week at all. My wife doesn't drink, period.
Okay.
She vapes. She doesn't smoke anymore.
Do you smoke? Okay.
I don't smoke. I haven't smoked in 30 years. And they found out I have a mild CPOD.
Oh, well, okay. So that's a lung issue, and then obviously your lung is what's responsible for bringing oxygen to the rest of your body. And it sounds like your wife was a smoker as well. That sometimes is just the reality of, I don't want to say, it's kind of like what's going to happen eventually if you've smoked. You can't expect, it's good that you guys have quit and that you're no longer smoking, but sometimes there are still repercussions down the line. And I'm not confident enough, obviously, over the radio to say that your muscle cramps are due to that. But I think the important thing here is if you've ruled out the more serious things, there's got to be something else that it could be, and it might be more lifestyle issue and diet related and those things. And in order to really identify potentially what that is, a lot of that is, number one, having a good, thorough examination. And really going through this in detail. And then the second part is a lot of it is trial and error, right? It's not going to be something that you necessarily will nail down on day one and say, yep, here it is. This is what it was. But sometimes it's a matter of, okay, try this and substitute this with that or whatever. And maybe those types of things make the difference. But again, if it's something that you and your wife are both experiencing, I would tend to agree with you that it does seem to be maybe something that's environmental, or maybe it's just coincidence, right? Maybe it's just, you guys get muscle cramps, and sometimes that's the reality of these things, is that they happen. And are you guys very active at all?
Not terribly, because when we do exert ourselves physically doing anything, we pay for it at nighttime. Like, it will wake us up. We'll wake up screaming in pain from the ball in my calf, and the pain will last me a week sometimes.
Wow.
I'll still feel the effects of it.
Yeah. So this is when
jump out of bed and stand on it, straighten it, make it stretch. And I'm telling you, man, oh man, I get it from my jaw sometimes when I yawn. I'll get a cramp in my jaw, my neck, and if I grip something, my fingers all go all wonky because they're cramping up on me. It's just
So if you guys are not active, this is where it's important. And I see a lot of patients like this who can't be active, or they think they can't be active because of the amount of pain that they therefore experience after they are active. This is where grading your physical activity is very important. So, maybe you start with a 5-minute walk for the first 2 weeks, right? You and your wife dedicate yourselves to 5 minutes, something that's very low intensity, not that much, and you have to progress. Oftentimes people who are physically inactive and overall not in good shape in that regard will want to get active again, and they'll right away jump to half an hour or 45-minute walk or something. Much, and then, of course, you're going to be sore that. Now, the whole point of exercising is that you will be sore the next day. That's how your body breaks down, repairs itself. That's just what happens with exercise. And sometimes when you push the limits beyond what you should physiologically be doing, you will get very, very bad muscle and joint-related pain for that.
Oh, I know that. Sorry to interrupt you. I know the difference between muscle pain and cramps. I'm a second-degree black belt in Taekwondo. I took Taekwondo for 9 years, and I know about exercise and stretching and all that. We're both 58 years old.
Yeah.
My wife's in reasonably good shape, except for her knees. I've had health issues in the past with my heart stuff. It's just, we lived in this house for 10 years, and that's been going on for the last 5 years.
Right.
And so, has anything really changed previously? No. Actually, we're eating better than what we did then.
Mm-hmm.
Right? We have better meals, more consistent.
Well, again,
protein.
Ed, if you're interested, I think the best option at this point is that we actually assess it and go through your history, your wife's history in detail to see. I'm just kind of spitballing ideas out there. And sometimes it's just a matter of trying different things. And if, and those different things might work. And sometimes grading the rehabilitation and eating better, there's always a way to do a little bit more for sure from a lifestyle perspective.
Right here, Ed, 1-855-55 Dr. Lou, DRLOU. Call that number or info@paincarecanada.com. Your phone calls, we got open lines, 416-870-6400, star 640 on sale. You have pain, you have concerns. Give us a call here right till 1 o'clock. Dr. Payne Show, Talk Radio, AM 640. 1223, Dr. Payne Show. Lots of open lines for you to call through with pain concerns, physical health concerns. This is when you want to call in and ask up till 1 o'clock this afternoon. Is it something else Ed could be doing as well? Because he's been trying to do this with his wife for so long. Get to the bottom of it. Keep a pain diary. You always talk about that.
Yes, yeah, and
right?
That's a great point. Just try to track exactly when these things are happening. In those diaries, you got to try to be as specific as possible because it's not a matter of 1 a.m. muscle cramp done, right? You have to be really specific. What happened that day leading up to it? What was the weather like? What did you eat? What exactly did you do? Was there something out of the ordinary?
As detailed as possible.
As
right?
detailed as possible, because it's kind of like a headache diary or pain diary, which we give to people who suffer with headaches or chronic pain or anything like this, is you maybe have to try to figure out, okay, what is it? Where is the common feature that we can see? And the only way really to do that is to go through that type of exercise. And although it's not necessarily easy and it's not necessarily a matter of only tracking it for a week. Sometimes it could take months, sometimes it could take years
right.
For someone to track those things the right way and to start to see a common feature. But I also wanted to continue with the discussion that Ed brought up, and not in Ed's situation in specific, but I do have a lot of patients who this is always a very, very tough conversation where they'll say, I want to exercise, but when I do exercise, I'm in pain. And I think you know this as well as I do, John. Most people, once they want to do something, they try to go all out in it. So
full bore.
Yeah, if they want to start eating better, they all of a sudden cut everything out, and then they wonder why it fails. There's something very, very important about a graded introduction of anything. So if you want to get more active, do that slowly. If you're going from 5 minutes and you were doing nothing, 5 is better than nothing. People think, well, if I'm not going to do 30 minutes, then there's no point. I might as well do nothing. Well, no. 5 minutes is better than no minutes. And then as that starts to feel more comfortable, then maybe you progress to 10 minutes. And you don't have to start at half an hour or an hour or 2 hours.
Yeah, there's no rush here. Take it,
It's the same as if you want to get healthy with eating. Usually you can do this. That's in a much more sustained way. If you look at your overall diet and you say, what's one simple thing that I could do right now where I could save a ton of calories? No more pop, for example. And let's just switch to water. And even that will be much easier for you to follow because you're not trying to juggle a million different things. It's not that big of a surprise. It's the same as people who are successful with cutting out smoking. Now, some people are successful by just going cold turkey and getting rid of it. A lot of people have to wean down. They have to use nicotine patches, the vapes, just things to change it up. But I think exercise and diet needs to also sometimes be done the same way. You don't need to necessarily go cold turkey and completely change something, 180. Just take it in steps, grade it. It'll be much better and much more sustainable.
It's amazing how it's hurry up and wait when it comes to those things. But if they decide to start taking guitar lessons, like you're not expecting to be Jimi Hendrix with
exactly,
a week and a half,
and that's a great analogy.
Take your time.
Yeah.
416-870-6400 star 640 on cell. Rick, good afternoon.
Hi there.
Hi, Rick. Go ahead.
Hello?
Yeah, we got you, Rick. How are you? Go ahead.
Good. I just the last 2 months I've started off with some vertigo and some hearing loss, ear fullness, and I've had a CAT scan, and the CAT scan came back clear. Mm-hmm. All my blood work is clear. I went and saw an ENT. My ear's fine. But someone was telling me about my SCM muscle might be causing all these symptoms. Have you ever heard of something like that?
Yeah, so the SCM muscle is the sternocleidomastoid, which is a muscle that it attaches from the mastoid onto the sternum. It's principally responsible for rotation and flexion of the head. Yes, if you tend to have trigger points, this is where where we've talked about myofascial pain before. Muscles can create a lot of these weird symptoms. It's the exact same thing. If someone had pain going down their left arm, the more serious thing that you'd want to rule out in that scenario is potentially some type of cardiac involvement. And then, once you're able to rule that out, there's no lung involvement, there's no neurological involvement, then yeah, it's probably a muscle. I think you're on the right step that, if you told me...
I can feel like swelling behind my ear right down into my collarbone. It's like I can feel in the morning, especially more so in the mornings, I guess because I'm sleeping on that side.
Yeah.
It's worse in the morning. As the day goes on, it does subside somewhat.
Yeah. And that's what I mean, based on what you're telling me, that you've had this checked out by different specialists for something more serious for that type of issue. And once you start to eliminate those things, that's when you can start to say, okay, this is just likely mechanical, because your muscles, your joints can cause a whole lot of weird symptoms in the body that are oftentimes very similar to the symptoms of very serious things. So if you're ruling those things out, then yes, there is the potential that the SCM muscle could be creating those types of symptoms, or other neck muscles in that region could be creating that. But that's something that's where we really specialize, especially is figuring these types of things out when it's something mechanical in nature. So if you're interested, come see us and let's see if it is the SCM.
I've been trying to do the self-treating, because apparently you just grab the trigger points and you just gently squeeze them.
Yeah, no.
Find these trigger points.
No. Don't self-treat. It's just not, no.
Yeah.
It never works. It's self-treating maybe, once you've had it treated and you want to try to manage it, someone could show you, but you should never really be self-treating these types of things. It's just, in order for you to do that, you have to lift your arm, you have to awkward positions. You're not actually being able to relax. And also you don't know, you're not trained in what a true myofascial pain syndrome is. If there's something else behind it, you need to have a professional do that for sure.
Okay.
Thank you, Rick. No problem.
Thank you, Rick. Moving forward, 1-855-55 Dr. Lou, DRLOU. That is the number to call. John, good afternoon.
Gentlemen, Dr. Lou, how you doing?
Good, pal. What's happening?
I've had a lower back issue, and actually a herniated disc in the L4, L5, which to the point where it was herniated, and had to have a microendoscopic surgery, or sorry for butchering the words. But,
okay. No, it's okay.
So I'm recovering on that, but my question would be, who would be like the point person for the overall back getting better, really? Because I have a neurologist, and he's more focused on, obviously, fixing the nerves and making sure that they're not pinched. And I have drop foot right now,
Right.
so I'm waiting for that to come back.
Mm-hmm.
But who would be the overall back person I would talk to?
I would say, a chiropractor who's obviously, what I'll say is more of a diversified approach, where they're dealing, not just focused on manipulation and adjustments of the back, but someone who's really focused more on the rehab stuff. And if you wanted to stick within the medical world, in terms of the, medical doctors, I would say a physiatrist, someone who's an expert in physical medicine and rehabilitation would be the best. You're right. A neurologist is really focused on the health of the nerves and curing those issues, or helping manage those issues, but they're not going to be the overall person for the back. But I would say, for someone who's primary care, very easy to get into, because a physiatrist may be a little bit more difficult, would be a chiropractor who's practicing that way. But that's easy. Just give me a call and we can help find the right person for you for sure.
Thanks, Dr. Lou.
No problem.
Thank you, John. 1-855-55 Dr. Lou, DRLOU, by the way, pals, that number, or info@paincarecanada.com through email. More of your phone calls coming up. Got to 1 o'clock. Bring them on. 416-870-6400 star 640 on your cell. Dr. Pain Show. Talk Radio AM 640. It is 12:32 in the Dr. Pain Show, right till 1 o'clock, and we're talking fibromyalgia. We're talking all kinds of autoimmune pain, all that stuff under that. People call in
back pain,
low
ear
back pain. It's coming.
Let's talk about a little bit more about the myofascial pain syndrome, because that is something that a lot of people experience that they don't even realize they're experiencing it. Because, if someone's got pain in the right upper quadrant of their abdomen, they're obviously going to worry that is something related to the GI tract, maybe the liver, maybe the gallbladder, maybe the pancreas.
Yeah.
Same thing as if it's up in the chest, you start to worry this is the lungs. And so this is exactly what happens. A lot of times the symptoms, the nerves that go to these different areas are all the same nerves. So if it's pain being generated by an organ or by a muscle to the body, it feels the same way. Now, I do agree that you need to rule out that it's nothing more serious. In that example that we talked about, someone starts complaining of numbness down on their left arm, out of nowhere, you want to make sure that that's a classic sign of potentially a heart attack. Now, sometimes you can easily rule that out because this person may be very young. They don't have shortness of breath. Their heart rate is fine. So it doesn't necessarily mean you need overly specialized testing. But in some instances, you might have someone who's 65, 70 years old starts experiencing that. And, they do have a history of diabetes or whatever. So, you start to rule out all these other things. But a lot of the times, once you've had everything ruled out and you're still experiencing some type of pain, a lot of the times what's left over is just the mechanical pain from the muscles and the joints. And that's a referral type of pain where those things are just creating pain in a certain dermatome pattern or sclerotogenous pattern, all these terms to correspond with different areas of the nerve that go to different places. So myofascial pain is something that a lot of people are suffering from. They don't realize it. And I especially see it with people who come in, and it's often related to GI issues. People who say, I've had pain, and they've done all the tests, I've been scoped, I've had all the blood work, blah, blah, blah. There's nothing there. They tell me everything's fine, but I got this pain. And then I start looking at it, and we start looking at the muscles in those areas, and sure enough, we find it, we treat it. These are the people that can actually get better quite quickly, because if you just release the muscle or you help treat that muscle that is creating that, and you teach people what to do to prevent it from going back into a trigger point, they get better. So it is much, much more prevalent than a lot of people think.
416-870-6400, star 640 on cell. Gabe, good afternoon. How are you?
Not too bad. Yourself?
Good. What's going on with you?
Well, okay. I'm a 58 years old. At age 16, I was diagnosed with juvenile rheumatoid arthritis, and I've lived with it for the last 42 years, and I'm in chronic pain all the time. And right now I take about 100 Tylenol 3s a month and some Percocets. I really hate taking Percs because they really screw you up. Wondering, is there anything that would help other than like for the pain? It really doesn't do anything because it just numbs me. It doesn't numb the pain at all.
Right. Yeah, it's a tough one, especially when you're diagnosed with something when you're younger. Have you had pain throughout your whole life from that point?
I've had both my hips replaced, one knee, and both shoulders.
Right. No, but I'm saying the chronic pain that you've had it ever since you were 16 after the diagnosis.
It's gotten progressively worse, yeah.
Progressively worse, yeah. So, unfortunately, sometimes that's the reality of once you undergo those types of things. I think in terms of, what is there specifically that maybe you can do, that's where I would need to assess you and go into much further detail. A lot of the times with these types of issues, it's not one thing that maybe could be done, but maybe if you try a whole host of new things, like really improving your diet from an inflammatory perspective, including exercise, minimizing stress, getting sometimes cognitive behavior therapy if there's stress issues or depression, anxiety issues involved. So there's so many things, but in terms of is there one new thing that you could try that would likely improve you? Probably not. It probably would have to be a whole new pain approach.
Oh, that bad. Okay.
Okay?
Okay, thank you.
No problem.
Thanks, Gabe. Moving forward, 1-855-55-Dr. Lou, DRLOU. We keep referring back to every show, for a portion of it anyway, CBT, cognitive. This stuff is so important, and it works so well.
Yeah, especially if there's a psychological component or any type of psychological intervention. I just often talk about CBT because I'm a big fan, because if you have a behavioral issue, then you should try to be changing that behavior.
Right.
But, something that he said there where he was kind of like, all of that, right? Like that's a very common thing with people who have chronic pain, and you have this conversation that, there are things that you can do. You could potentially get better, but it's not going to be easy. And most people react that way. They're surprised. They're like, wow, I didn't realize it was that much. This goes back to the conversation of I was just expecting a quick fix or a pill or some new procedure that's been invented. It doesn't exist with pain. It does not exist. If you're serious about getting out of pain or managing your pain, call me. I want to talk to everybody, 1-855-55-Dr. Lou. But be prepared that I'm going to give you the brutally honest truth of all the things you have to do. If you come to me and I identify that you have a psychological issue or that there's a psychological component to your pain, I'm not going to shy away from telling you that that's the case. If you come to me and you're overweight and I believe that that's contributing to your pain, I am not shying away from that.
Sure.
And people are going to get that honest answer from me. So if that's what you're looking for, then please absolutely call me, because that's the only way to really get better, is if you're willing to hear
confront it.
Yeah, the truth is sometimes is not easy, and it's not easy to hear, and a lot of times people don't want to hear, but sometimes you have to do a lot of different. I had a person the other day who came to see me, and they were talking about some breathing issues, and they're wondering if there's some things that they could take to help their breathing. And as I went through their history, I end up finding out that they've been smoking for the last 40 years, and that they smoke about a pack a day. And they were kind of like, and I was like, well, the biggest thing you could do for yourself is quit smoking. And they wanted nothing to hear about it. They're like, no, not here for that. I know I could do that, but what else could I do? It's like, well, if you don't do that, nothing else you do is really going to matter, right? And it's just incredible that people sometimes don't want to accept this stuff.
Hi, Pete. We'll get you in before the break. How are you?
Very good. Thank you, doctor.
No problem.
And I'm currently on heart medicine, and I thank God for the surgeons and so forth that frankly saved my life.
Okay.
My only concern is after 4 years on these meds, is there any way to lighten up on them? Am I incorrect in thinking that this is going to build up with time? Because it seems like I'm taking a ton of drugs.
Yeah, and I think that is a much better question to ask with the people who have put you on those medications. I'm not in a place, obviously, to answer. Sure. Sometimes, unfortunately, sometimes with medications, and I'll answer this as a blanket, broad statement. Sometimes with medications, you will unfortunately be required to stay on them for forever, and sometimes over time, actually increasing the dosage. Other times, depending on what the issue is, sometimes you can be weaned off a medication and maybe put onto something else that's not as severe or strong or whatever it may be. But that is a conversation that you have to have with your professionals that have specifically put you on those medications. And I think an important aspect is a lot of people are afraid to ask that. They're afraid to go back to their healthcare professionals, their doctors, and say, hey, what's the long-term plan here? Like, is this something that I'm on forever? Is there another option? Can you give it can you just explain to me where are my options here? So if you do wean me off of this and you put me on that, what are the side effects of this? If I do decide to go off of it, what's the risk to me? At the end of the day, remember, the one thing that everyone should remember is you are the person in charge of you. You never have to do anything or take anything if you don't want to. Exactly. But just remember that to take into consideration the opinions of these professionals, because they're likely putting you on something because they've already looked at the risk-benefit ratio. I'll give you an example. My mom suffers from COPD herself, and her respirologist, who's a good friend of mine, does his best to minimize the amount of corticosteroids she needs to take in order to help her breathe. But sometimes when she gets sick, she's exacerbated, he ups it and then he brings it back down. But will she ever be off a corticosteroid? Absolutely not. But he does do his best to try to minimize it. And he's always said to me, like, because corticosteroid use over a long period of time is potentially dangerous. But what's more dangerous? Not being able to breathe. So it's a similar type of situation to you, Pete. You really have to look at, I don't know what your heart issues are. You have to look at that. You have to speak with those professionals, engage it from their perspective of what's their long-term plan. And I'm sure if you ask them that question, they'll be more than happy to help.
Absolutely. No, I have a wonderful, relationship with my doctors.
Great.
Awesome.
And I certainly listen to everything they tell me because I don't know
keep
what
you
they
alive.
know.
Yeah, exactly. You leave it up to the professionals, and that's the way to do it.
Yeah.
But be an informed person. That's like anything, right?
Yeah.
You got to be an informed consumer, even in healthcare.
Thank you, Pete. Your phone calls 416-870-6400 *640 on sale. Got some more time to 1 o'clock to call into the Dr. Payne Show, Talk Radio, AM 640. It is 12:44. We go till 1 o'clock here on your Saturday afternoon, the Dr. Payne Show. Outside of the show hour, 1-855-55-Dr. Lou, DRLOU, or info@paincarecanada.com. Get that free consultation, have to make your first move and get on it. We've been talking about and focusing a lot on pain on the Today Show because it's a Dr. Payne Show, but it's different. It's not necessarily from breaking a foot.
We deal with pain and maladies.
Yeah, you're using my word again.
Yes, I'm never letting that go.
$5 every time you use it there,
okay.
buddy. $5. There you go. CBT, we just talked about that before we talked to Pete and how important that is to get your literally mind around it. And, it's great therapy, but it takes work, and it shouldn't be a point of embarrassment for anybody. I've been through it. You've done it.
And the other thing is a lot of the professionals that you deal with, whether you realize it or not, they may already be implementing some type of a behavioral therapy, maybe not necessarily in a true formal fashion of a CBT, but I know a lot of the people that work with me that aren't specifically dealing on the psychosocial issues, but even the chiropractors, the physiotherapists, the massage therapists, education, reassurance, all of these other things work on the behavioral aspect of understanding pain and being able to accept it. And that's very, very important. And so it should not be dismissed. It should not be looked down upon. People, and the other thing is I had another person this week who I was talking to about this, and I said to them, it sounds like you need to implement a good, behavioral program into your therapy to really get around a lot of the psychosocial issues that you have with your pain. And they basically said, well, no, I've already done that, and it just really wasn't for me. And I said, well, what have you done? I went to speak to someone, and they told me about CBT. And I said, but that doesn't mean you've done CBT. Yeah. And they're like, no, we worked on some stuff. And I'm like, no, CBT is the equivalent of changing your lifestyle if you want to get healthy. It's not something that you do from, September 1st to November 1st, and then you stop. It's a change of your behavior. You don't, at a certain point, it doesn't even need a term because you just change the way. It becomes part of you. Yeah, it becomes part of you, and you have to work hard at it. And depending on how long these issues are going, usually people who have like an anxiety or depression issue, this didn't just start yesterday. This is sometimes going on for decades, years. You need to work at these things for a very, very long time in order to see even sometimes a small effect. But if you don't start at it, you don't change. It's the same as the path to really getting healthy doesn't happen overnight. If you're overweight and you all of a sudden want to get really, really healthy, you don't snap your finger and go to the gym that week and eat healthy and then all of a sudden that's it. Everything's crystal clear. No, it takes you changing your life. And these people sometimes take years to completely turn around, and then they finally end up changing, and then they think back to the way they used to be, and they're like, I could never be like that again because it's just not me anymore. It's the same thing on the mental side, on the psychosocial side with your pain management. You have to be able to look at these things every single day, do the exercises that are involved with it. And by exercises, I just simply mean the right things that you should be doing around changing your thought patterns. Mm-hmm. Sometimes pain management is also about accepting it, not letting it control your life. And that's a big thing. A lot of people make the pain that they experience bigger than them. You can minimize that perception. You can come to terms with it and say, no, yes, I have pain. It's part of me, but it doesn't control me. And again, if you said that once or twice, that's not going to make a difference. But if you repeat that hundreds of times, thousands of times over many, many months, many, many years, I guarantee when you look back, you'll say, yeah, they're still there. It still does control my life sometimes, but it's not like it used to be. Yeah. And so these things really, in pain management and most things in healthcare with the management issue, it's not easy. You got to do it long term. If someone has diabetes, you don't just cut out breads and pastas and the sugars and starches for a week and then say, my blood sugar's back down. I'm not diabetic anymore. No. The rest of your life, that's what you need to be doing. And if you don't do that, then it will progress, it will get worse, and it could lead to other very, very serious problems. And psychosocial issues are the same. I've seen people who experience that, were high-functioning individuals that, CEOs of companies, and then all of a sudden they developed an injury, they developed chronic pain, and their lives literally change where they go from the top to the bottom because not that they've let it take them over, but it just happened. Overwhelming. And that's how serious pain can be. People think pain is just like, oh, you got pain. And that's what I'm saying. That's how I started the show, by saying that a lot of people that suffer from chronic pain, that have issues, will tell their friends, their loved ones, and they're often dismissed because it's just like, yeah, but you're fine. You're walking around. You don't look like somebody in pain. You don't have to look like somebody in pain. Disability and pain are two very different things. And you could be a perfectly functioning individual with high levels of pain. And some people who are very disabled have no pain. They're two absolutely different things. And yes, sometimes they do correlate. But in a lot of scenarios, people with chronic pain, fibromyalgia, are high functioning. There's no impairments, and yet they have this pain. And they're often dismissed because it's like, no, you look fine. You're there. You're sitting. You're getting up. You're moving around. What's really wrong with you? No, that's not the way it works. And that dismissal of that only makes these people worse. So even if you're someone who's listening and your loved one has been told they have fibromyalgia or chronic pain, don't dismiss that. You're not helping them by dismissing it. You need to help them accept it and deal with it is much more important than just saying, no, you're fine. It's all in your head. No, there is a component, yes, but anything that's in your head is theoretically the realest thing, right? Like your mind is what makes everything real. And yes, chronic pain, when we've talked about the example of phantom limb pain, people who have lost a limb and still experience pain, that is clearly a pain syndrome being constructed in the mind.
Yeah.
But that is very different. To say something is constructed in the mind and experienced in the mind is very different than saying, oh, it's just in your head. No, there are two different things there. The mind controls everything. It's the motherboard. It's creating your reality. If you shut that off, nothing's real anymore. You're brain dead. You're done, right? So, you can have pain that is created in the mind, but that does not mean it's not real to the person. They feel it's just as real as anything else.
And like you said, it's so individual. Your pain's different than my pain. The
Absolutely.
way Jody feels pain, it can be completely different. So
100%.
you can't brush it off.
No,
you can't brush it off.
One of the questions that we ask people is when we ask them to rate intensity of pain, we'll often use a 0 to 10 scale, 0 being no pain, 10 being the most pain you've ever experienced in your life. The next question after we say, what is it, 0 to 10, is what's a 10 for you? Because a 10 for you may have been, when you fractured your tibia, versus a 10 for me is
a heart attack.
Right. Or usually with women that have given birth, they say giving birth was a 10. So it puts it into perspective for you on how does someone experience a 10.
Still have a few more minutes. You want to call in, have an opinion, have a question, please bring it on here at 1251 to Dr. Payne Show. 416-870-6400 star 640 on your cell. Dr. Payne Show returns. Talk Radio, AM 640. It is 12:53. Once the show is over, you can contact either that email or the phone call and get a free consultation happening. Rick, good afternoon. How are you, pal?
Hi. Well, I'm just for the last year or two, I've just had a constant pain in my head. Like it's like a nervous pain. I can't get rid of it. I've tried a few things.
Okay. Where exactly is the pain in your head?
It goes in the middle to the front and on the sides. And I've had MRIs. There's nothing wrong with me.
Okay. What else have you looked at? Have you had blood work?
Yeah, blood work. I've had heart checked out, everything like that. And nothing's wrong with me.
Mm-hmm. So a lot of the times, again, this goes back to myofascial pain. A lot of the times with head pain, once you've ruled out obviously more serious things, which it sounds like you have, a lot of the times it's just simply related to the mechanical structures, and more specifically when you're dealing with head pain, that being the neck. So a lot of you can get cervicogenic or tension type of headaches that are just really due to the joints and the muscles in the neck for whatever reason, poor posture, life. Like none of us in life actually have good posture. So, posture related issues can create tension on those muscles, on those joints. And then it corresponds with the nerves that, go into the head and supply the skin. Because, that the most of the head has cutaneous innervation. Half of it has cutaneous innervation, meaning the skin is innervated by nerves coming out of the neck. But then again, going back to referral patterns, a lot of referral patterns from the neck actually end up, in different parts of the head, whether it's on the temples, the front of the face, in the forehead, in the eyes, around the sinuses. So it sounds like if you've had other things ruled out, that's probably where we're headed, is that it might be something that's just simply mechanical related to the neck. Do you have any neck pain?
There is some tightness in the neck too, but nothing really.
Yeah. What do you do, like, in terms of, do you sit a lot during the day? What's a typical day like for you?
Yeah, I'm sort of semi-retired now, so I sit a lot, but I still get out and do everything. It's just.
Are there times that you find that the head pain is worse, like something that you can specifically identify and say, yeah, definitely after this type of, I don't know, activity or food or whatever, it feels worse?
No, nothing like that, no.
Okay, so this is another example of keeping a diary around it would be important, because then you can start to look for some common features.
Right.
But again, in my experience, this is very, very prevalent, and it's often related. Again, once other things have been excluded that are more serious, it's often just simply related to the mechanical issues of the neck and the posture issues. How old are you, Rick?
61.
61. Have you had your neck x-rayed or anything like that?
Well, I don't know if they did that when they had the MRIs or not.
No, they wouldn't go into the neck. They would if it was of the brain, they would just stay within the brain, and if it's of the neck, they'll go into the neck. So that may be something to also consider if there's some degenerative changes that may be putting pressure on nerves and creating a stiffness component. But again, you don't necessarily have to have neck pain to have it's kind of like when people have disc herniations, for example,
right,
and they'll feel symptoms in their leg. But they don't have any back pain. So it's similar, except it's on the other end. It's at the top of the body, where you can have issues in the neck that create pain in the head, but not necessarily pain in the neck. And although the the genesis of that pain, the originating component of that pain is in the neck. So, so definitely give me a call. That's very, very easy to check out and figure out if that's potentially where it's coming from.
Oh, I will do that. I'll follow up.
Okay. Thank you, Rick. I appreciate that. It is 1-855-55 Lou, DRLOU, or info@paincarecanada.com. I mentioned it a few times, got free consultation. Get it started, right?
Just give me a call. It's very, very simple. I get lots and lots of calls. I do my best to get back to everybody right away. If I'm delayed a little bit, it's just simply because I'm really busy. I've got a lot of people calling, trying to take advantage of what I'm doing. And really, if it's even just a conversation, you want to be pointed in the right direction. Like, should you be going to see your family doctor for this problem or somewhere else? Just call 1-855-55-DRLOU. It doesn't cost you anything. Leave me a voicemail. Obviously, if it's a medical emergency, call 911. Don't be calling me and leaving me a message. But if it's something you need an opinion on around your pain, specifically pain, musculoskeletal pain, health issues, just give me a call. It's very simple.
Don't have to rush to emerge.
Yeah, just exactly. Send me an email, info@paincarecanada.com, or go to paincarecanada.com and you can get all the relevant information there. Nice. And it's not going to cost you anything. There's no commitment. Just simply call me. Let's have a discussion.
Till next time, the Dr. Payne Show right here, Talk Radio, AM 640.